I've seen a fair bit of trauma, and probably the hairiest one was a young man who was in really bad shape, and we used all our blood, and we had to transfer him, and I ended up running an adrenaline infusion. Hi, my name's Gaby Blanch. I'm an emergency physician in New South Wales. I find that when people come in having had a collapse in the community, they often have been sat up by bystanders and given something to eat or drink. And yeah, I'm not sure why people do that. When I was doing retrieval a few years ago, we had a patient who was quite a nasty trauma, a motorcycle accident, and he was intubated on scene. He had bilateral finger thoracostomies, and we were en route to the trauma centre when his tension pneumothorax kept reaccumulating. So I only had the airway kit close by, and chest drains were in the back of the kit. So I put an endotracheal tube into the thoracostomy hole, inflated the cuff, and it did the trick. But I had to be really explicit on handover at the trauma centre that I knew that that's not what those tubes are normally for. Yeah, that's when you decompress a tension pneumothorax with a hole and a finger.
Can you explain how you do it?
Yeah, so you an intubated patient will make an incision in the ribs. It's just like putting a chest drain in, but you use your finger just to ensure that the lung is up and to allow any trapped air in a tension pneumothorax to be released. I've had a couple of asthmatics over my career who've needed to be intubated, and I would say every single one of them have been the most terrifying moment of my career. I guess you tend not to intubate asthmatics until they're really on the brink. So you've got a patient who's physiologically really at the end of their tether, and intubation could kill them. And then once you've intubated them, the hard work starts, ventilating them. So yeah, really scary stuff. And one of them was a child, but they all did well. I think I probably speak for most emergency physicians when I say that we still freeze in and are paralysed with fear, but the duration of that paralysis gets shorter. It used to be minutes, now it's seconds, and hopefully one day it'll be microseconds. But usually there's just a short pause, and then your training kicks in, and your teammates, your colleagues help get you there.
What's a good way to overcome the paralysis?
I think just falling back on your training, yeah. Because in that moment of fear, if you can just, find your way to your algorithms or, your first steps in your resus, then you can usually, get going from there. I've seen a fair bit of trauma, and probably the hairiest one was a young man, different motorbike accident, and he just was in really bad shape, and we used all our blood, and we got more blood, and then we used all of that, and we had to transfer him, and I ended up running an adrenaline infusion because it's all I had left. I'd even used my hypertonic saline for a little bit of volume replacement. It was really hairy. I think it's, emergency medicine's a team sport. So you lean on your colleagues, you debrief, you joke, and then, try and find a way to put it behind you when you drive home and then try and enjoy your family.